Okay, so apologies if this case is a little bit less descriptive than I would normally do, but I've been on annual leave, so this one was quite a quick one I tried to put together today. So this lady is a 28-year-old, gravida 3 para 2, BMI of 31, with 2 uncomplicated SVDs in 2012 and 2020. She had no medical history that was necessary to mention. O positive, bloods as you can see there, HB116, platelets 142 and white cell count 6.8. She's a sickle cell carrier, and her last ultrasound at 32+1 was for GDM when they found normal fetal growth Dopplers and Lycor, and the baby was on the 50th centile on her gap chart. She doesn't speak any English, and she was a late booker with some safeguarding concerns as well. So she came into triage on the 20th of the month. GDM was diagnosed, by the way, at 27+2, and it wasn't particularly well monitored just due to a language barrier and difficulty in communication, but the BMs that were taken were absolutely normal throughout her pregnancy. So she was an induction of labour for gestational diabetes at 40+2, and this is her triage CTG. The plan was made for admission and for induction of labour, with a 6-hourly CTG as a protocol. Okay, everybody happy? Normal trace, baseline 140. Acceleration, so happy antenatal trace.
Yeah,
Okay.
I think it's okay.
Yeah, fabulous. Yeah. I agree. So on the 20th at 11:24, she had a CTG which was normal and a ProPress was inserted. Her os was closed at this point, mid-position, and presenting part was -3. There wasn't a CTG performed following insertion of the ProPress. So just to highlight out the fact that we should be monitoring babies for 40 to 60 minutes following prostaglandin insertion, and for a period of time beforehand as well, so a minimum of sort of 20 minutes or so, just as a sort of key message going forwards from this. I think I also wanted to mention in this case that how important it is to document the timings of what you're doing, because with this lady in particular, I find it quite difficult with the documentation that was written down to actually determine when things were happening for this lady, just in this period of time. But yeah, she had a CTG at 18:52, which was normal, and she was tightening at that point 2 to 3 in 10. Then at 04:30 the following morning, so much longer than that 6-hour protocol, this is her follow-up CTG. And the contractions that you can see below here, as you can see, quite regular. However, they were mild on palpation and the woman wasn't in very much discomfort at all with all of this. But are we still happy?
Yeah.
Yeah, fabulous. This is oh sorry. Yep, so that's all good. She then had her ProPress removed after 24 hours. Her cervix was found to be 2 centimeters dilated, but still not fully effaced, still posterior. And she was confirmed to be ARMable at this point. So this was the 21st, so this is the day after. Normal trace? I think I heard a yes. Amazing. And this is just a bit more of it continued here, which is lovely accelerations. And those contractions from that 4 a.m. Episode have kind of calmed down a little bit, although not the way that we would like them to. We'd like them to actually continue to intensify and get slightly longer. But yeah, good variability, stable baseline, and it's stayed the same throughout as well. So this is her final hope ward CTG. Unfortunately, due to activity on that day, they couldn't bring her around for an ARM for quite a significant amount of time, just due to activity. It was a very busy day this day. So yeah, still again, same stable baseline, normal variability, which we like to see. And that's a bit more continued. So now on the 22nd at 00:48, she was transferred over to labour ward. Happy with this one?
Yeah, I think there's enough cycling there.
Yeah, absolutely. So if the first sort of 20 minutes was something that you saw for longer than 40 minutes, we'd start to get a bit more suspicious. But yeah, we're seeing this baby's sympathetic and parasympathetic nervous system are completely intact, as we're seeing periods of sleep cycle as well as periods of activity as well, which is great. Although I don't know why the toco wasn't put on at this point. I don't know whether the toco and the mum's fetal heart rate monitor got confused or whatnot, but it looks a little bit bizarre at the bottom there. I think it's mirroring a maternal pulse. But yeah, so we're moving on. So cannula was sited at 02:10, and her observations there, as you can see, are completely normal. And baby's cycling again, which is good. In that period of slightly reduced variability there. Although what's going on with her toco, I'm not quite sure at this point. I think that says that toco passed on or something like that, or put on. I'm not sure why it wasn't put on for this period of time, but I think we'll start to see some differences in the next section. Happy still?
Yeah, I guess happy.
Fab. Okay. So the CTG continues pretty much exactly the same for the next few slides. So I'm going to whiz past them because it's more of the sort of end of the trace that I think is worth sort of speaking about more so. But at 02:35, she had an examination for to perform the ARM. She was found to be 1 centimetre dilated, so there was difficulty in performing the ARM. And then at 02:45, the midwife in charge was successful, and pink liquor was draining. And as you can see as well, reassuring factors is that baby's responding to those examinations with those accelerations, as you can see. So we've got a very intact central nervous system at this point. So we go on break relief. Again, still episodes of cycling, accelerations are present, good variability. And it continues. Tell me if anybody wants to stop, but it's quite a long segment of trace that we can see here. So she's ARM'd at 02:45, and the plan was to remove her from the CTG monitor just to give her some time to mobilize. But they decided to keep it on. It's not particularly documented why. But due to the fact that everything was completely normal with her, other than the gestational diabetes, which was diet controlled, by the way, I don't know if I mentioned that, she was kept on the trace for quite a substantive amount of time. So break relief midwife here, and then we continue. And then the CTG was taken off at 06:40. She was having some mild tightenings, which were sort of 1 in 10, if that, which were midwife found to be mild on palpation. So yeah, 06:40, she was removed from the CTG. Sorry, that's a lie. At 04:30, she was removed from the CTG, and then at 06:40, she was put back on the monitor after 2 hours of mobilization. And as you can see, observations still remain normal at this point as well. Any question? Oh, and her BM is 5.8 at 7:10. Any questions? Were you all happy to continue, move on?
Yes, happy, thank you. Move on. Thank you.
Lovely. Again, we're continuing. This baby was clearly didn't really mind the waters breaking, which was great. But yeah, and then at 07:25, she was re-examined and found to continue to be 1 centimetre dilated. So the plan was for oxytocin augmentation to help her progress in through her labour. At 08:15, as you can see, blood pressure slightly raised. Now I think she's starting to feel the contraction slightly more, but we still haven't started Synto yet. The midwives have documented that it's all prepared and in the room, but it hasn't yet been prescribed by one of our doctors, so they weren't able to start it, which is best practice, which is a really good thing here. But yeah, we then did a urine sample at 09:26. She had 2 pluses of ketones, a plus of protein, and a trace of leukocytes. believe this protein plus urine sample was sent off for a PCR as well. But it could have been a bit of a combination of anything, specifically now that we've ARM'd her as well. And the ketones, because she hasn't probably eaten in the last 12 hours at least overnight. But it's documented that she had a nice meal for breakfast this morning. So 0942, our oxytocin has started at 3 mils per hour as per protocol. I just wanted to highlight that this made me so happy in life that this lovely midwife has documented on the electronic noting bit of the CTG and highlighted it here, that we can actually document on the CTG without having to write through it with pen. For those of you that know, this is a little pet peeve of mine. So yeah, I just wanted to say, for anybody that's on this call, this is what you can do, and it makes it look an awful lot easier to read, and is much clearer. At 10 o'clock, blood pressure is still slightly on the raise, 133/86 in comparison to what it was before, but absolutely normal and within range, and pulse is still stable at 85. Moving on, so as per Synto protocol, we're doubling our amount every 30 minutes. CTG classified as normal, everybody agree?
Yeah.
Great. And again, we've moved up again. She's gone out to pass urine again and passed 250 mils of clear urine. She's contracting 1 to 2 in 10, but they're mild on palpation. And observations again remain absolutely stable. Does anybody have any questions at all?
Tara, there are a few people who just joined in. Can you just very quick briefing about the history? But just to mention, so far everything has been good. But just to mention the history of this lady, because few people literally just joined in.
Absolutely. So this lady is a Gravida 3 Para 2. She's 40+4 now. She's an induction of labour for GDM on diet, and she's had 1 ProPES inserted, and then's been ARM'd at that's a good question. 0245. 0245 pink glycol draining, and it's documented as being clear throughout the rest of this as well. So yeah, we've just had very good episodes of cycling. This baby is doing well, sat at a baseline of now sort of 135, 140. Good accelerations, and it's been stable throughout. And Synto was started sorry, at 0942, after she didn't make any progress with the ARM. Where are we? So yeah, observations at 11 a.m. still normal. Still contracting sort of 1 to 2 in 10, and they are remaining mild on palpation. At 11:50, Synto's increased to 24 mils per hour. She's now 2 in 10 almost all the time, and mild on palpation. Fresh eyes at 10 past 12, and was discussed as a normal trace. She's currently in some discomfort, but nothing that she's requesting analgesia for at this point in time. Observations again still stable, as you can see there, and her BM is 4.6. This lady's BM's been well controlled the whole way through her labour as well. Any concerns here? Anybody disagree with normal trace, or are we all happy still? Okay, I'm going to go with happy, so I'll move on. She's given 1 gram of IV paracetamol at 12:40, just to take the edge off. Still contracting sort of 1 to 2 in 10, as you can see. Trace remains pretty much identical to the whole segment of this case so far, which is great, and observations still remain stable. And we'll move on. So 13:50, she goes out to the toilet. Any concerns with this one?
The deceleration towards the end.
Yeah. What would we classify this deceleration as?
Is it late?
It is late. In terms of physiology, I don't know who that is that's speaking, sorry. But in terms of our baroreceptor and chemoreceptors, do you want to try and classify?
So we have offered in a new on the basis that I do want to. So around that they're doing.
I don't know if anybody's speaking, but I can hear some background noise. Anybody else want to comment? Baroreceptor or chemoreceptor deceleration?
Hi, Cara. They look more chemoreceptor because they're sort of biphasic. It's when the deceleration is starting, it's carrying on for a bit before it recovers back to baseline. So I
Yeah,
wouldn't
absolutely.
call it baro. I'll call it chemo because it's lasting a bit long.
Yeah, and slower to recover. So that yeah, I totally agree with you there, Petronella. I think that's Petronella. Tell me if I'm wrong. But yeah,
It is.
okay. Okay, so she's gone back out to the toilet, and then she's returned at 14:05. You can see that there's some loss of contact on the CTG. She was put into left lateral as the deceleration was heard again, and that was found to be audible at that time, although we can't see it here on the trace. So the Synto was stopped at 14:10. She had an examination performed by her midwife at 14:15 and was found to be 9 centimetres. However, was asked the midwife in charge to recheck it because she was unsure. And at 14:20, the midwife in charge examined and found the lady to be 4 centimetres dilated with the presenting part at -2. So this lady has finally got herself into active labour. Any questions? Are we happy with the CTG continuing?
Yes, I think it's beautiful.
Lovely.
Happy to continue. Yeah, definitely.
Fabulous. So we're moving on again. So the Synto was then recommenced at 6 mils per hour. There's some loss of contact, as you can see, at 14:58 there, although audible decel was not recorded at this point. And then moving on at 15:05, she was changed back to left lateral. I'm not really sure why in this case. If anybody else has any other ideas, please do shout them out. And then at 15:25, the registrar came in to examine her and found her to be 6 centimetres, but not effaced and presenting part now actually at -1. And as you can see, observation still stable there. Blood pressure 130/79, and her BM is still within normal range. Anybody have any ideas as to why this may have been the case, or? No. Any of the regis on board want to know maybe why this registrar came in to re-examine? I know there's a few of you on there, and I remember your names, so I'm going to start calling out.
Cara,
Yeah.
Could it be that there was a discrepancy in VEs? Just go back a bit on the information. Is it the was it yes? So because of the discrepancy in vaginal examination, where the midwife made her 9 centimeters, and the coordinator made her 4 centimeters.
Mm.
So I'm thinking that's the reason for a registrar's examination.
Yeah, although the registrar was actually present when this examination was undertaken. Sorry, I didn't mention that. So when obviously I've been looking over this, and it's not really documented the justification for it, so I'm a little bit confused. I totally get where you're coming from, but it would have made more sense to me to have done this earlier than to have done it, what, an hour later. But we'll move on. I'm going to assume that was probably the case. But anyway, this woman, despite everything, is progressed, which is great. So she's now 6 centimeters, but not effaced. This is our next CTG. 1539, the anaesthetist is now present because this woman would like an epidural. However, has left the room as thinks that birth is imminent, and was the midwife that was caring for her was under the same impression, just due to distress. Then at 1609, the anaesthetist came back into the room to attempt the epidural once again. What do we think of this trace now?
There's slightly
Sarah.
increased ability for, sorry, Mr. Nagy.
No. I just wanted to ask one question. Sorry, Maya. How is it 6 centimeters and not effaced? Can you explain that to me?
I would love to explain it to you, Nagib, but I asked myself the same question because when we perform vaginal examinations, obviously they do help us in terms of making plans of care for labour and whatnot. However, I was always taught, and I've always been under the impression that if a lady is 6 centimeters, if her cervix is uneffaced, it's not technically a labouring cervix. So whenever I teach my students, whenever I'm supporting any junior colleagues with performing examinations, you always have to ask yourself, actually, 4 centimeters, 6 centimeters, you could have somebody that's what you may think is 8 centimeters with a very thick or long cervix, with a high presenting part as well. The likelihood of their sort of progression at this point, if their cervix isn't fully effaced, is unlikely that their labour will progress well. So from a midwife's perspective here, I don't know whether our registrars would agree or disagree, or our students would agree or disagree, but if I was feeling a cervix that was more 6 centimeters but was not fully effaced, I would have explained 4 centimeters. And I wonder here if that's what the midwife in charge has also done. But obviously now we've got this woman's now had 3 examinations in the space of an hour. Moving forwards, trying to make any kind of care plan for her is going to be difficult because we've got such a large discrepancy. But tell me, does anybody else have any thoughts on that? I know that there's a few of you doctors on there, but I'd love to know.
For me, Cara, 6 centimeters, and you want to describe it as uneffaced, I would describe it differently. I would describe it as 6 centimeters but swollen cervix if you want to label it as uneffaced, but it's not uneffaced. The effacement and I mean, when we say 3 centimeters fully effaced, but if it is 6 centimeters and still not effaced, this is a swollen cervix rather than effacement. It has a different description. So yeah.
And also in terms of a swollen cervix, Mr. Nagy, what would your thoughts be if it was in fact swollen and not uneffaced?
So swollen cervix, there is many reasons, of course. There is one reason that she is pushing on a non-fully dilated. The second thing is contraction, and it's strong, but the head is high and it is just coming and going, like not compressing on the cervix so much. There is many reasons. I can't justify in this situation what is happening exactly, because some people are saying -2. So I feel like the head is not pressing on the cervix. She's GDM. I'm assuming it is macrosomia as well. So irrespective of the CTG, I like to see the patient as a whole, and I can't see her as a whole in this situation. I feel like they are managing pieces. They are managing the CTG alone, the examination alone. I can't put them together yet. Maybe I will make sense of it later. Maybe. Yeah.
Perfect. Maya,
Tara,
what were you
I
going
think
to say about the variability?
the variability is increased in this strip, but just to kind of touch on that, I think this baby is OP and probably this is caput. So I have a feeling, obviously, macrosomic baby that is still not kind of like really descending OP baby and with a significant caput. So I'm not sure if the VE has touched on the amount of caput or anything else, or just they describing the dilatation of the cervix.
So the exact words documented were 6 centimeters, not effaced, and presenting part -1, but there wasn't a comment on any caput or molding or fetal position at this point.
That's fine. Maybe later we will find out. Maybe. Yeah.
Perfect. So I'll move on. So things took a bit of a drastic turn. At 16:20, the registrar came in and was present. A decision was made to go to theatre. She did an examination, and this woman was now anterior lip, LOP, and at spines. And then at 16:33, Synto was stopped. What would we like to see happen here?
Sorry, Cara. The decision was to go to theater for cesarean or for examination. What was the wording?
So the wording was decision to go to theatre. It was then later, I think, documented that the decision was made to move so that we could then re-examine in theatre and either attempt a trial or an emergency cesarean section.
I mean, I would like stop the Synto, give it some time to settle. If anything, just let this baby relax, and the variability is still maintained. I mean, I know it's like a 4-minute, 5-minute, if you want to call it, decel, but the variability is maintained. Just give it some time to recover and don't lose that trace. So probably, I don't know, if you're struggling with the trace, put an FSC, but keep on monitoring. Just don't stop it there. That's what I think. I don't know what did you want with your question. What were you looking for?
Any sort of anybody to sort of say how can we make this better? How can we make this settle? Because clearly you've said everything that I was going to say, Maya. So I obviously, when we're getting this loss of contact, we're not really seeing it here. We've got really good contact here. We can sort of tell from the differences in the examinations as well that baby, although it has come down by a plus, has now come down, so that could affect our CTG monitoring abdominally, just due to the fetal position. But also an FSC could help us to pick up the trace a lot better. And the fact that we're getting this loss of contact and making a decision 10 minutes before our Synto's been stopped was something that I just wanted to highlight. If we've got CTG concerns like this, we need to do what we always do, which is stop the stressors. So thinking, okay, do we have meconium? Is there oxytocin running? Do we need to consider terbutaline in this instance? But the main thing that is from this is making sure we've got that contact with the monitoring, so that we can determine, actually, we can see we're getting good periods of variability here. But is this baby going to return back to baseline if we just stop the Synto and just see if it improves?
I think it was stopped at a very critical moment when actually you should wait and see if the intervention you've done is actually getting the effect you're looking for. So any intervention you need to do, you need to see the effect of it. And I'm afraid it's not kind of like within 1 or 2 minutes. It's not like magical stuff you do in 1 or 2 minutes and then it will correct itself. So I think, yes, I agree. Just wait for the improvement secondary to the intervention you've done. Do resuscitation, stop the Synto, if anything, consider terbutaline. The variability is maintained. It could be due to descent. It could have like descended all, especially in view of the discrepancy before. It could have been high head and now it's like fully at spine. And then just keep on looking and then make the decision. I think I would have done that. I don't know if anyone agrees.
I agree, Maya. Sorry, hi, my connection's been bad, so I haven't been able to jump in. Hi, everyone. I just think this baby's been so happy beforehand. We haven't had concerns about it. This is a multip. And so although we need to act on that CTG acting can be stopping the Synto, stopping her pushing, and giving that baby time to recover. If you want to move to theatre and watch it, that's totally fine. But you need contact and you need to just resuscitate the baby.
Absolutely.
I agree with both of them, but I feel there was some degree of panic in the atmosphere, really. The coming, examining, 3 examination, 4, 5, 9, then 4, then head is -2, then spines. There is a bit of a commotion happening here. So I think the maybe the answer of the registrar or the team is get her away from the room and manage her in theater. So I think there is an element of a panic, or yeah.
I think you're right, Miss Nagib. She was pushing. It's a lady that was pushing voluntary from the time she was 4 centimeters.
Yeah, this is what we thought, because the way that it is described, the way the staff is acting, as if they are reacting to something we can't see on the actual CTG, something on the background that, pushing them to act.
Absolutely. There was a language barrier as
Yeah.
well. There was a language barrier. She spoke absolutely, I know the CTG now. She spoke absolutely no English and she was pushing from the time that Synto was started. Very difficult case to manage.
And in many of those situations, the staff tend to want to terminate the situation by delivering her and ending the drama. So yeah, I it's not that I'm agreeing with the situation or with the CTG, but I'm trying to think beyond the situation, really. Yeah.
Perfect. We then had a bit more discrepancy. At 1640, she entered theatre. At 1641, spinal was inserted. This was done quickest spinal I've ever seen documented in my life. At 1646, a VE was performed by the consultant. She was found to be fully dilated, OP presentation, and at spines. At 1657, due to the fact I think they were going to try a trial, and not an indwelling catheter, an in and out catheter was inserted to drain the bladder. I've put those two timings the wrong way around. Apologies. 1655, indwelling in and out catheter was inserted, and then at 1657, an examination was undertaken by a different consultant. Didn't determine the dilatation in the documentation, but documented that the head remained high and that the decision needed to be made for an emergency cesarean section as the consultant was unable to manually rotate this baby, and this baby also had a deflexed head.
May I ask something, Cara?
Mm.
This lady had objection to epidural, or what was exactly going on with her?
No, she didn't. She just didn't want one. It's documented that it's offered on a regular basis, or any kind of pain relief is documented. The team that were working with this lady spent, I think, the majority of the entire labour on language lines, obviously gaining consent for things. But she didn't want any pain relief up until the point where I think they determined her 6 centimeters, and that's when she decided she would like an epidural.
I mean, I agree. If she's someone who's been pushing from the beginning, as Petronella said, on her cervix, and she's OP when we diagnosed her, she's someone who I would like to have a epidural in. But yeah, if it's kind of has been discussion made throughout, then obviously she definitely did not want it.
Yeah, I think that's the impression that I got, that that they were sort of recommending an epidural, but she did decline. She didn't want to have one until obviously we got to about 6 by the registrar.
Was it a massive baby on scans?
No, 50th centile.
Okay.
And when the baby was born, the baby was also on the 50th centile.
And she's not a petite lady, because I think I missed the BMI bit.
31.
Okay, so that's adequate, to be honest, isn't it? Okay.
I can't remember if the Apgars or the gases are next, but I just this was when I kind of stumbled across accidentally when I was trying to look for somebody else's notes, and I just thought that it was quite an interesting one. Obviously, with the multiple examinations, and obviously it's always difficult whenever you're caring for anybody with a significant language barrier. But yeah, this specific sort of slide in particular interested me, just because let me ask, if we were in hindsight, would we have done anything differently to this?
I think resuscitation measures try to relax the baby and then try to buy time for a passive hour. Maybe that would have got the head lower, but you still have to kind of push it up to impact it, do manual rotation or a metal cup. See if that helps, because from my understanding, they try to do it manually and the baby did not move. So literally kind of just give baby some more time to make vaginal delivery more favorable, I think, just in hindsight, obviously, to see if your resuscitation and making the environment better, because the baby has been fine throughout. I mean, even now, looking at what I can see from the baseline, it's still around 140. This is just the last bit there, when probably they were trying to manually rotate it, isn't it?
This bit here, yeah, at the sort of 5 p.m. mark, that's when the consultant
until this stage, this baby is fine. So the baseline has not shifted a single bit during the whole labor. The variability has been absolutely fantastic. So to be fairly honest, the only thing I would think of is would we have benefited anything from waiting 1 hour from passive? Would that had added anything to making vaginal delivery more favorable? Could we have used another instrument if manual rotation we could not rotate it manually? Could we have used a metal cup or a kiwi rotation? Not sure, but obviously at the time that's different. They might not described in writing the difficulty step by step of rotating that baby. I'm not sure. Maybe that's the only thing I would have done different. I don't know if anyone else. Natasha, what would you think?
Yeah, I mean, it's really difficult when you're not in the situation. And from what Petronella was saying, it sounds like she was an incredibly difficult woman. And I suspect the multiple examinations came from her saying, you know, baby's coming, pushing on a closed cervix and being a multip. You know, it's not unreasonable to examine again. You know, if you'd have given her time, maybe the CTG would improve, maybe not. The CTG certainly looks bad enough that if you couldn't resuscitate the baby, you certainly would have wanted to expedite delivery. But it's hard to tell when you're not in that situation. I know how difficult they are.
Perfect. Mr. Naguib?
I think someone just made a comment. I don't know if anyone can go to the chat, saying maybe she was in so much pain. A comment from someone I don't know.
Mr. Naguib?
Yeah. I am trying to get to the chat to see the comment, but yeah.
Hi, it was me who said that, Catherine.
Hi, Catherine. Yes.
Hi.
What was the comment? Because we cannot bounce outside.
If she was in a lot of pain because she
Huh.
didn't have effective pain relief,
Yeah.
and then there's loss of contact, maybe that's why they thought of going to theatre in case, you know, things escalated.
Yeah, you're right.
And also the language barrier as well.
Yeah. The what I can say in this situation is very simple, and I concur with Natasha and Maya. The situation here seems from the beginning that it is a difficult one, and unfortunately, in many of those situations, and of course, you know, like many of us are foreigners, and similarly the language barrier and so on. But some of us come with the ideology of our back home, and some of that I meet is that they don't want pain relief. And even when the woman wants pain relief, the husband is objecting to the pain relief. And I encountered this many times, that the husband is saying no epidural and so on. And I think personally, at the fully dilated time, in my opinion, this was the right course of action, proceeding for section. In my opinion, we lost the battle from 3 centimeters. We lost the battle long time ago. If she would have relaxed, as the comments said, with an epidural when she was 3, if she didn't push on the cervix, if she relaxed so the head can rotate and she doesn't push, if many things would have happened, I think it would have maybe had a different outcome. But at full dilatation, I find it extremely difficult, especially when I examine under anesthesia and spinal is on, and we put the legs up or examine her in lithotomy and the head is still at spines or -1 with OP. You are and in your back of mind, you have a GDM on with a possible macrosomia, with not with like in the back of your head because of GDM. I know the scan was normal. I think the battle has been lost long time ago, and again I would repeat it. Obstetrics is an art. It is not managing and reacting. I like to proact, not react. If I'm acting long time, I will win. It is a battle and a chess game with the dilatation and with the baby. So yeah, I think at this situation, fully with all the commotion, section is the best for her. Not a difficult instrument.
Petronella has her hand up, so go ahead.
I couldn't agree with Mr. Naguib more because I was involved in this case. In hindsight, if I could paint a picture perfect, I would say start talking to this woman about pain relief in labor in her own language before the induction process even started. She had no idea about any forms of pain relief in this country for labor. And that in itself set us up to fail. So nothing we were advising her to do in labor was welcome. She wouldn't have anything. She said, I've had 2 normal deliveries, I will do it again. But then the other 2 normal deliveries were not induced. She was not mobile. She was just lying in the bed all throughout the labor. And if I could perhaps look back, I would get this woman more mobile in her labor. I would offer early pain relief. She didn't necessarily need to have this cesarean section. Ended up with a cesarean, but I feel like it could be avoided by simple things as pain relief.
But then you actually highlighted a very, very important point, is that probably the patients with language barrier that we could identify antenatally, we should not only counsel them regarding their antenatal care, but also like use that opportunity to discuss postnatal care, including like specific time probably to explore analgesia and make sure that they have a appropriate understanding and appropriate time to grasp, especially if they have kind of like a cultural objection to epidural. Maybe that could be something that we could highlight for future antenatal clinics and antenatal care, and maybe we can do special sessions for those who are interested. I think that's a very, very important point you raised, Petronella, especially in this case.
Amazing. Does anybody want to guess the gases in the APGARs?
Seven 7.32, 8, 10, 10.
Anybody else?
Eight, 10, 10.
APGARs of 9, 10, 10. Gases, arterial 7.22, base excess minus 3.7. Venous pH of 7.29 and base excess of minus 3.1. Perfect. Does anybody have any additional comments that they want to add? I think this one's definitely highlighted some really, really important points in that antenatal education needs to be much better when we're discussing sort of birth options and whatnot, specifically even more so with our women that do have that language barrier. If she has come from a different place and doesn't speak the language, then it's so important that we